This video demonstrates a laparoscopic assisted pull-through for anorectal malformation in an 18-month-old male child. The child had had a previous colostomy performed elsewhere in which the sigmoid colon was pulled up to the right hypochondrium in the position of the right transverse colostomy. 3 ports were inserted for the procedure: an umbilical port for the telescope, a left upper abdominal port, and a right abdominal port inferolateral to the colostomy position for the hand instruments. Here is the local anesthetic being infiltrated into the left abdominal port position. The umbilicus was entered with a number 11 scalpel blade. The opening dilated a little. And a 5 mm trocar inserted and sutured in position. This was connected to the CO2 line and a 5 mm 30-degree telescope inserted, which showed the sigmoid colon extending from the pelvis at the site of the fistula up to the colostomy in the right hypochondrium. From here, the proximal bowel doubled back towards the pelvis and then towards the left abdominal wall as the descending colon. This shows the entry point of the right abdominal trocar, which is just below and lateral to the position of the colostomy. And the entry of the left abdominal trocar. A grasper is used to divide the single point adhesion. Visualize the bladder and the vas deferens. A silk suture on a large cutting needle was used to lift the base of the bladder away from the site of dissection. This opens up a space behind the urinary bladder, thus providing easier access to the fistula. There you can see the vas being removed from the traverse of the cutting needle, and the bladder being lifted up by the silk suture. The left hand vas is clearly visualized, and the right hand side vas deferens can be seen just above and to the right hand of the rectum. As the patient had a colostomy in the right hypochondrium, the bowel was pulled towards the right side and dissection was therefore begun on the left of the sigmoid mesentery. We all know that the triangle of dissection for an anorectal malformation is bounded laterally by the ureter and distally by the vas deferens. And the space for dissection is between these two clearly visible structures. So using coagulating current on the right angled hook electrode, the mesentery of the sigmoid colon is dissected from the left side. The aim being to get behind the rectum and into the natural plane which leads down into the pelvis, and also to go through the mesentery to the other side for adequate mobilization. There is the ureter of the left side, visualized through the sigmoid mesentery. This is not the usual situation in anorectal malformations, where the patient mostly has a sigmoid colostomy, that is the left vas deferens. However, if we had performed this operation by the open approach, he would have had a long infraumbilical incision as well as an incision to mobilize the sigmoid colon pulled up to the right hypochondrium, and a third incision to site the sigmoid colostomy. So despite the unusual situation, the decision was made to perform the procedure laparoscopically, thus cutting into the abdominal wall as little as possible. Section then shifts to the right side of the sigmoid mesentery, and the first visible tethering band is divided to open up a space from which to divide the mesentery further. The vas deferens of the right side can be seen entering towards the bladder base. and that opens up a potential plane through which the dissection can continue along the fistula into the pelvis. The right internal iliac vein is visualized with the testicular vessels crossing over it. Due to the abnormal position of the colostomy, the right ureter was difficult to see at first, but gradually as the dissection progressed, it became visible and the dissection could be done safely away from it. The dissection was then brought back to the left side, and in a similar manner, alternating between the right and left sides, the back wall of the rectum was delineated, a plane opened up for entering the pelvis, and a passage dissected through the mesentery of the bowel. When convenient, the hand instruments are changed from the right to the left side to facilitate the dissection. And here we can see the plane of dissection adjoining the fistula, which will eventually lead us into the pelvis. And just underneath the dissecting hook, we can see the right ureter as it courses towards the bladder. This forms the lateral boundary of the dissection triangle, and the anterior limit is formed by the vas deferens. As the distal bowel is quite dilated, manipulation is a little difficult. Changing the position of the grasper on the circumference of the bowel can help to open up more planes of dissection. At all times, it is helpful to stay close to the wall of the rectum because that prevents us from damaging any adjoining structures. As you can see, the ureter is rather close to the wall of the bowel at this spot, and therefore, as the dissection proceeds, it gets somewhat skeletonized. It is good to stay as far away from the ureter as possible because the heat generated from the cautery hook can has the potential to damage the ureter. Therefore, if at all conveniently possible, the ureter should be moved away from the line of dissection as quickly as possible. It is a common observation in surgery for anorectal malformations that if a colostomy is incorrectly performed, as in this case, there is a lot of dilatation of the distal bowel because the mucus which is secreted in the distal loop does not get a chance to get out of the colostomy. As you can see here, the cautery hook snagged a mesenteric vessel. It's probably a small bleeder which, however, because of the magnified view of the telescope, creates a largest looking pool. These vessels tend to retract into the mesentery, so the only way of controlling them is to continue with the dissection until you can coagulate at the site where the bleeding is appearing from. It is preferable when going across a vessel to coagulate it at more than one spot before dividing between the coagulated areas. Because of the bowel dilatation, the mesentery is also thick, and therefore a lot of dissection is required to get across it to the other side. In this sort of situation, there isn't any faster way of doing this other than to cautiously dissect your way through, go by the feel, and wait for the correct planes to open up. With the mesentery of the rectum as thick as in this patient, it is a good idea to keep thinning the mesentery at one point where you feel the rectal wall is above, and eventually this will afford a passage through to the other side. When dissecting on the anterior surface of the bowel, it is always better to divide the peritoneal adhesions a little distance away from the vas and then push them bluntly distally, taking the vas with the peritoneum. Coagulation close to the vas deferens should obviously be avoided. So, attempting to find the gap in the mesentery below the inferior limit of the rectal wall, the dissection continues to reduce the thickness of the rectal mesentery. Occasionally, you encounter a lymph node, as seen here. And finally, the gap appears which gives a way through to the other side. And just to make sure that it is actually a gap and we haven't opened the rectum, a grasper is spread in the small opening. Due to the dilatation of the bowel, of course, it is not immediately visible on the other side. But by manipulating the rectum, we are able to confirm that we have gone through the mesentery at one point. From now on, things become a little easier because we have a fair idea of where the inferior limit of the rectum lies, and we can continue enlarging that small aperture until we get a sufficient rectal mobilization. One of the most troublesome complications is opening of the rectum. However, it's not very difficult to manage as you've got a proximal colostomy, so a couple of sutures put in to close the aperture work very well. Even when the aperture in the mesentery has been delineated, it is advisable not to coagulate very thick sections of the mesentery at a given time, but to work one's way through slowly until adequate mobilization is achieved. Some of the larger vessels in the mesentery usually do not get completely coagulated using the cautery hook and may retract into the mesentery to cause troublesome bleeding. So just checking to see that it's safe and that the hook is traversing the mesentery. We continue with the dissection of the mesentery to narrow down the fistula, moving both upwards towards the sigmoid colon and downwards towards the pelvis to achieve adequate mobilization. As you can see, the size of the bowel due to dilatation makes for somewhat difficult handling, but there is no quicker way to do this rather than to keep patience and keep dissecting until sufficient mobilization is achieved. So we are through the mesentery at one point, and this is a great advantage because you can now build up on this gap to safely mobilize an increasing length of the rectum and use this as a guide to dissect around the fistula into the pelvis. It's now possible to appreciate the thickness of the mesentery which occurred due to the bowel dilatation in this patient. However, we can see that the actual fistula is quite narrow, and it was only the thick mesentery which was making it appear large in diameter. Just a quick change of instrument hands here to continue with the anterior dissection. Now that we've got a gap behind the rectum, it's easy to keep away from it while narrowing down the fistula progressively. However, anteriorly, we can see that the two vasa differentia course quite close to the fistula in the distal part, where they terminate into the seminal vesicles, and therefore the dissection has to be kept literally on the wall of the rectum to avoid damaging these structures. Standard laparoscopic dictum has it that you should not cross your hands while using instruments, but it's all about the convenience and the most ergonomic way of providing traction and counter traction on the tissues so that the planes you want to dissect are clearly displayed. If you have to cross your hands sometimes, there's no harm in doing it, so long as your instruments don't battle with each other. So again, trying to stay safely away from the vas deferens and the seminal vesicles, and keeping the dissection close to the wall of the rectum. The rectum is really very large in caliber, so it takes a bit of maneuvering to get the tissues into proper position for further dissection. Once you've got the gap and the posterior limit of the rectal wall clearly delineated, as we can see here, one can be a little braver and cut through thicker bites of tissue. However, it's still better to be careful. So we continue to narrow the fistula down by dissecting the strands of it all around. Always using the gap behind the rectum as a guide to get the proper plane. Um this bleeding is a result of one of the surface vessels of the rectum getting torn by the teeth of the grasper. One should be careful to grasp the rectum at a point away from a vessel. However, with bowel of this size, sometimes manipulation causes this kind of bleeding, which of course in a magnified view looks far more than it actually is. Another disadvantage of bleeding is that it obviously obscures the planes of dissection, especially with the clot collecting in the pelvis. So it is advisable to wash the blood out to give the correct visibility. And occasionally these little vessels prove to be a little stubborn. So once the bleeding is controlled and the blood washed away, we get back to our dissection. Some blood is still collected in the pelvis around the distal fistula, which is suctioned away, and we continue narrowing down the terminal rectum, moving from whichever direction is convenient. As you can see, the right ureter is somewhat skeletonized in its distal part. This should be avoided, but in this patient, because of the bowel dilatation and the proximity of the ureter, some of its adventitia in the distal part has gone away. We are continuing to progressively narrow down the fistula, dissecting from the anterior, the right, and the left sides, and now approaching the prostatic urethra. At this point, we can clearly see the terminal rectum narrowing down to continue into the fistula. This child had a prostatic urethral fistula. One of the useful things to do before division of the fistula is to put a suction catheter into the distal limb of the colostomy and evacuate all the contents, the mucus, some accumulated stool, and most importantly, the mucosal blood that has oozed into the lumen because of the terminal rectum being grasped during dissection. This prevents any soiling of the operative field when the fistula is divided, and as you can see here, occasionally also opens up a coagulated blood vessel. So we continue the dissection on the ventral aspect of the fistula, staying very close to the rectal wall at this point because all the structures like the ureter and the vasa deferentia seem to converge towards each other at this level. Even though the fistula seems quite large from the outside, once you actually begin to divide it, quite a lot of tissue gets divided on all sides before you reach the rectal wall and open the lumen. For obvious reasons, it is safer to divide the fistula from behind forwards, as you open the lumen at one point and get a guide to the wall of the rectum, and then you can divide the walls individually anteriorly until the entire width of the fistula is cut through. But this is a matter of personal preference. I suppose if the anterior limit is equally clear, division can be taken from before backwards. So here we have entered the lumen of the rectum, and once this is done, the walls can be divided individually, little by little, taking care to preserve the adjacent structures. At this level, we begin to see the pink mucosa of the fistula in the center, and we can appreciate really how thick the wall of the rectum is as it is getting divided. So the near wall of the rectum has been divided, and we proceed with the division of the far wall. Just a few strands left. And that completes the division of the fistula. I have not ligated the fistula in any of these patients and have not had a rectourethral recurrence. Once the fistula is divided, it is possible to appreciate just how small the opening is in the rectum due to the proximal decompressing colostomy. There's a bit of oozing of blood from the site of the divided fistula, which is probably coming from one of the vessels in the wall of the rectum. It's not a very major bleed and will probably stop by itself. Having divided the fistula, it was now turned to mobilize the colostomy because, as we saw earlier, the sigmoid was actually going across the abdomen like a bowstring, and without taking down the colostomy, it was not going to be possible to get the rectum out to the skin. As we could see the colostomy clearly from the inside, it was decided to take it down using the cautery hooked, and additionally a piece of gauze was packed into the colon to prevent spillage of contents when the site of the colostomy was transferred from the right hypochondrium to the left iliac fossa. So this is the colostomy in the process of getting dismantled from the abdominal wall, from the peritoneal aspect. After mobilizing the colostomy, we proceeded to do the perineal dissection. As mentioned, this child had had an attempt at perineal digging, and this caused a bit of scarring at the site of the neoanus, and you can see the dimples where this digging was done. In such cases, it is sometimes difficult to distinguish the correct place where the neoanus should go, and in such cases, it is useful to remember that the horizontal line joining the most prominent point of the two ischial tuberosities should cross through the center of the anal opening or immediately in front of it. And using that landmark, we made our incision. You can see the white scar tissue, which denotes the place where an attempt at an anoplasty was made in the first operation. Sutures to open out the scarred area and facilitate the tunneling into the peritoneal cavity. Now, using the time-honored technique of dissection through the center of the external anal sphincter, which you can see contracting a little in response to the diathermy, and following this we use the standard technique of spreading through the external anal sphincter using a blunt pointed hemostat with the tip turned downwards. It was not totally easy because the first surgeon had dug a little deeper than anticipated. Therefore, we had to cut through this scar tissue to get into the correct plane, which was somewhat 2 centimeters deep from the skin surface. Once, however, I could feel the scar tissue had been traversed, Further dissection was done using the blunt artery forceps, keeping parallel to the operating table. That is the direction we need to go. Keep parallel to the operating table. And with this sudden give way feel, you know that you are through the sphincter and into the peritoneal cavity. There is a gush of CO2 and a little collected blood. During this dissection, two things are important. One is to stay strictly in the midline, and second, to stay parallel to the operating table. In a patient like this where a previous operative intervention has been attempted, things are not so easy as in a patient where the first operative attempt is being made. The scar tissue extends deeper than is apparent from the surface, and therefore the dissection lasts longer. Finally, the tip of the artery forceps enters the peritoneal cavity, and it is spread a little to create a passage to let the dilated rectum and the terminal end fistula through to the perineum. There are many ways of pulling down the mobilized rectum through to the perineum. A 10 millimeter trocar can be put in through the anoplasty incision. A grasper can be inserted through this to catch the rectum and bring it out to the perineum. However, I have seen in these cases when the bowel is dilated, it does not fit into the tip of the trocar. The technique I have adopted in this patient is to put the artery forceps into the peritoneal cavity, look at its tip through the monitor, and use a grasper to feed the dilated rectum into the jaws of the artery forceps from above. This requires you to work against the front to back paradox, but it can be done with a little practice. Due to the large dilated rectum, a little bit of pulling is required to bring the fistula down to the perineum. However, with a little traction, we were able to get the tip of the rectum out to be sutured to the skin for the anoplasty. It's a time-honored principle of doing an anoplasty that accurate mucocutaneous apposition has to be achieved all around. Some degree of anal stenosis is bound to occur because every anastomosis will shorten by a third, but this can easily be taken care of by a period of postoperative dilatation. Once two of the anaplasty stitches have been inserted, the artery forceps holding the bowel can be removed and the rest of the mucocutaneous sutures inserted to complete the anaplasty. There is no particular sequence in which these sutures are inserted. You can proceed clockwise or counterclockwise along the circumference as the need may be. Here we have divided the fistula in the posterior midline to enlarge the opening a little because there was a discrepancy between the narrow opening of the fistula and the size of the anaplasty incision. So these are the last few sutures to complete the anoplasty, and we then remove the two traction sutures. The next part of the operation is to resite the mobilized colostomy at its proper place in the left iliac fossa. So for this we closed off the site of the left hand trocar. And grasped the mobilized colostomy in a grasper, made an incision at the left McBurney's point, and under vision from below opened the incision down to the peritoneum. The colon was then handed up through the incision at the correct site of the colostomy, and after opening the peritoneum, the colon is delivered. Initially the opening was made a little too small, so it was suitably enlarged to deliver the colon and anchor the colostomy in place. It's not wise to try and drag the colon out through an opening which is too small, because we can do unnecessary damage to the colonic wall. So we orientate the colostomy correctly, excise the part of the margin which has skin attached from the previous site, and then use the seromuscular and the mucocutaneous sutures to form the colostomy. So this is my resident making a thorough job of fixing the colostomy to the underlying muscle, after which she'll put in the mucocutaneous sutures to form the colostomy. Finally, a couple of stitches to close the umbilical port, and that brings us to the end of the operation.